just like I'm doing here. So we have the patient sitting back. I put it's called a lift limb. I like them because you just raise the limb up, give them the little injection. Once that's done, roll over to their side. You got the vision block. They don't even see it. They're watching TV. And you just go. Okay, so folks, this is, in my opinion, this is the most important slide. It is. I'm telling you. In my opinion, if you're really serious about minimally invasive surgery, I really feel like you need to invest in a fluoroscope. They're getting to the point where they're really not that expensive. I mean, I've seen them on eBay for as little as $5,000. Okay, so that's extremely low, but you can get them for that price. I've actually seen it with my own eyes. But here's the deal, folks: if you don't have a C-arm, I really wouldn't even consider doing a lot of this stuff. I mean, wouldn't you agree, Don?
Yeah.
Wouldn't you agree? Yeah. I mean, you got to have a C-arm, folks. So if you look at this, we bought some muslin drapes from Gill. We sterilize them ourselves, open up in packs, put it on. That's Katie. That's my assistant. I can tell you right now, she knows instruments as well as anybody in this room. At this point, and I've been doing this now 3 years, I don't even tell her what to do. She has all the packs ready to go, everything ready. We're ready to rock and roll. So if you're looking at an approach, I like to use a lateral approach. If you look at that small little incision site, that's usually where I go in from the lateral side. It tends to work very well. And then if you're looking at how to put the burr in, you stick it right in there. Be very careful. Again, this is small Hagelin's deformities. I'm not talking about large Hagelin's deformities. Go in there. Use like a windshield wiper. If you look at this book, folks, I would highly recommend this book. I actually have 2 copies, and I have the video along with it. This is actually chapter 16. This is a bargain. I think it's around $300. I would highly suggest you buy it. This is in chapter 16. If you do this, if you're very careful, use it. Use the burr, the small little burr, and you should be fine. So if you're looking at this is another view. Obviously the patient has the vision block. They're on their belly. I'm doing the procedure. C-arm drape is on. And if you look at a pre-op image, now this isn't the best view. I don't know if you can see it, but right in here's my small little blade. You can see it pointing up. Okay, so going in there, grinding it out, grinding it up here. It's really not that long of a procedure. Okay, if you really know what you're doing, I like doing these. Again, it's a matter of selecting the right patient. Okay, so if you're looking at this is not a lot of blood. It's mostly bone paste, so we're squeezing out the bone paste, okay? And right now, I'm actually going to stop. I have 2 pet peeves. One of them is if a doctor says they're too good to do nursing homes, I get mad because I started doing nursing homes. One of the reasons why I have all that equipment is I did nursing homes. I saved up every dime and I bought all this equipment, okay? So if you're too good to do nursing homes, you're going to get in big trouble with me. Another thing that's a pet peeve of mine, if you get up here and talk about how good a surgeon you are, and you don't have any complications, and you act like you don't have any complications, you're not doing too many surgeries, okay? So I want everybody to look at this. This is a burr. I broke it, and I broke it in my operating room, okay? What happened was, this guy was a vet tech, so he used this before in animal clinics. He was awake, and what happened, I broke the bit off. It's too small of a burr, okay? That was my fault. I messed up, okay? And what happened, I told him, I said, look, man, I broke this burr off. I can't get it out. I've got an eye magnet here, and I can't get it out. It's bleeding. So what I do, I had to put a stitch in it. And I said, look, we're going to have to go to the ASC. I'm going to have to take it out. And if you're honest with people and you admit you made a mistake, I think most of them can live with that. If you act arrogant and you mess up, they're not going to be too forgiving. So what happened? We had to take him to the SC. He wound up getting a $5,600 bill. Whose fault was that? Mine. Okay, I admit it. Okay, but in my defense, I was trying to save the guy $5,600 by taking him to my office to keep him from having that bill in the first place. Okay, so that's kind of the way I look at it. Some of you might disagree, but I'm trying to save some people money. Do high quality surgeries in the office, save people money. I think in the long run they're happy for it. So if you look at post-op, I say non-weight bearing for 1 to 2 weeks. You can kind of scratch that out. That's kind of a misprint. I like to go anywhere from 2 to 4 weeks. So again, that's my fault there. Cam boot, typically you can go anywhere from 4 to 6 weeks. I'm a scaredy cat. I try to make the incisions as small as possible. I try to get the patients in and out with less trauma. If you look at this photograph, this was in McGlamory's. So if you look at the one on the left, pretend that's your Haglins, and then a surgeon says, hey, I'm going to take off a little bit, and then you look and you say, you know what, I can take a little bit more of the spur off. And then you wind up going over to the third one, and you're going to take even more off, and take more off, and more off. Then you decide, hey, I'm going to take a little bit more off. You wind up cutting into the Achilles tendon. For me personally, I like to leave a little spur on it. And that's just me. I don't like it super smooth. I mean, when a rock climber wants something to grab a hold of, okay? My goal is to reduce the size of the spur, maybe not get rid of the whole thing, okay? Because if you're doing that, I just, personally, I don't want to have complications. So, before I end, I have a small video on YouTube that I'm going to show you. I'm gonna let you ask me some questions, but I'm gonna end with a little bit of humor. This is my aunt. She died at 103, and we were looking at her old files, and it was in 1948, and she had a surgery, okay? And this was her bill for her surgery in Terrell, Texas. And if you look at this bill, and you look at the operating room costs, the dressings, the anesthesia, yada, 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 it's $70.50. Okay? If you look at the surgeon bill next to it, it's $100. So she had a grand total of a bill of $170.50. And here's my point, okay? And Seth Reining's going to speak about this, and I think he would agree with this. What do you think the ratio is now of doctors' pay to what the hospital makes? Okay, look, the doctor's making $100 here, and the hospital's making $70.
Yeah.
Probably now,
10%.
what would y'all guess?
10%.
10%. No, I think it'd be 20 to 1. I do. I think it'd be 20 to 1. Yeah. I mean, isn't that unbelievable? Yeah. My how times have changed. Okay, so that's my lecture. Yeah, we can try the video. And by the way, I actually.
I can ask you a question.
Yeah, you can write me. You can ask me a question, but for me, I wrote a fellowship paper about the advantages of in-office surgeries, and I'm a believer in MIS, and I'm a believer in doing it in the office. If you can't, it's all about patient selection. It's all about patient selection. I'm the most anti-surgeon. I'm the most anti-surgery surgeon you'll ever meet. Try to get patients better without doing surgery. But if every bit of my ammo belt is out.
Here's a question.
I think when you broke the burr, you have to understand the equipment you're using.
He's got it right outside.
Hang on, just a second.
When you're doing these procedures, you have to understand the material you're working with. Burrs at the surgical neck of the burr, a new burr, takes 500 grams of pressure. So you have to let the burr do the work rather than pressure doing the work. So you have to realize where the pressure is at the joint of the burr at the neck. That's 500 grams of pressure. You start using a push, that's when they break. So you have to know what your equipment can do.
You could just go to YouTube, East Texas Foot and Ankle Center's Haglins, Yeah. Here's the thing, guys. If I can't get it up, you can just get on East Texas Foot and Ankle Center's Haggins for me. You got it? Yes, sir.
This is in reference to last year. I'm sort of curious, and I could be wrong about this. A lot of before I was not a big fan.
Okay. Laporta is up here. I'm down here. Laporta's the best surgeon I've ever seen in my life. Not even close. I mean, you have these famous guys like Lowell Scott Weil, and I'm sure he's great, but Laporta was the ultimate, okay? I can tell you Dr. Laporta's philosophy. He's probably one of the most open men you'll ever find when it comes to procedures. Wouldn't you agree? I mean, I try to be open-minded. Okay? I like traditional surgery. I like MIS. I think Don would say the same thing. I'm going to try to get the patient better any way I can, but yes, to answer your question, Laporta is very open to different techniques. If it's a new technique that he thinks is going to be better for a patient, he's going to do it.
I've never seen him do this.